yeah, this is the vascular surgery curriculum that we're putting together for the Rwandan general surgery residency. My preceptor is Dr. Benjamin Brook. He's a vascular surgeon here at the U, and I'm Mariana Street. So we've been working with the University of Rwanda in Kigali, Rwanda. They do have an established general surgery residency, but as was mentioned before, they do not have this vascular surgery curriculum. You can go to the next slide. So we were given a document that was about like 11 to 12 pages. That's just a screenshot of the first page. So kind of to start off, I'll just kind of go through the process of what we've done so far is we kind of read through their proposal, I guess, what they had, kind of edited a few things straight off the bat, revised a few things, mostly just like made editing changes, but didn't do too much as far as changing goes, just kind of read what they had at baseline. You go to the next slide. So then we read the U of U vascular curriculum. So they have like a pretty extensive document and the things that they teach their residents here. So went and read through everything that they have, compared it with the document that Rwanda has, and kind of identified, highlighted the gaps, the things that the University of Utah had, as well as the things that Rwanda had, and tried to fill in the gaps that Rwanda had, the things that need to be kind of beefed up in their curriculum.
Can you talk a little bit about what those were? What were the gaps that you saw, and what were things that maybe didn't apply? Or
yeah, so most of the, I guess, gaps that you could say, which kind of I'll talk about at the end, were things that we have here at the U that we are able to implement that they may not be able to do over in Rwanda. So things like laparoscopic surgeries or different like aortic surgeries, like and Dr. Brook, I think since he's a vascular surgeon, he would be able to kind of speak more to the specifics on this, but it seems like they may have some limitations on the surgeries that they can do. And so at baseline, which is kind of where we are right now, we just said, here's what we do at the U, and we implemented it in their document. But we will have to kind of bring it back to them and say, are you able to do these surgeries? And they may have had those gaps in their original document because they don't have the capacity for that, or the instruments, or things like that. Does that answer your question, Dr. Jerry Robin?
yeah, it's a good, it was a good place to start. So why don't you carry on?
So their outside or I kind of went through outside resources. So I went through this SCORE document, which is kind of like the ACGME guidelines, as well as this other ACGME program requirements for vascular surgery. These are just documents that I found online. They're kind of public access. The things that vascular surgery, or I guess general surgery residents need to be able to complete in order to be trained in vascular surgery. Also looked at this integrated vascular surgery residency at NYU and saw what things that they had available and the things that they required in order to be graduated from their program. So yeah, kind of like pulled outside resources and identified things that needed to be supplemented in the Rwanda program. And so then we went from this kind of bare bones document. I think another thing I didn't mention as far as gaps go is there was not a lot of detail or explanation as far as the way that they had outlined things. And I think I would probably have to kind of like show the entire document to explain that. But if, for example, if they had like an aortic aneurysm repair in their document, they just kind of said aortic aneurysm repair. Whereas on the University of Utah's document, they said aortic aneurysm repair. A student, in order for a student to be able to complete and graduate this vascular surgery like training, they need to be able to do these things regarding an aortic aneurysm repair. So it was kind of adding, like supplementing details, verbiage, different things like that to what they had originally, because there was not a lot of detail or explanation as to the different procedures and surgeries that they had written down. So on the left is kind of their original document that they had. This is just the first page of it. And on the right, this is kind of where we have it at the moment. Just kind of adding more things that the residents need to be able to do, and kind of like more in depth as far as exactly what the residents are expected to do, so that when someone reads it, they can kind of, I guess, like I said, understand in more depth of what residents need to be able to do in order to graduate. So as far as like where we are now, it is kind of just in its initial stage of proofreading, checking things for spelling. Dr. Brooke is taking a look at it right now. He will pass it to Dr. Longwolf, and I believe Dr. Jayaraman, you're also a part of this. And then once it's kind of gone through our staff here, as far as like proofreading and things like that, then we will turn it over to the Rwanda General Surgery Residency faculty to see the things that they feel like need to be changed or altered. And this kind of goes back to what I was saying at the beginning. We are unsure, or at least I am unsure, of kind of the capacity that the Rwandan team has, like what they can do as far as surgeries. So we just kind of gave them all of our tools that we have here at the University of Utah, as well as what the ACGME requires. And we're just kind of giving them all of that, and then we can see what they have the capacity for. And then so in the future, I think it is possible that we'll be able to go visit Rwanda to like learn and see what they do as far as their general surgery program goes, and potentially have opportunity to teach different vascular surgery procedures and collaborate further to see how we can supplement their program and give them support and help them get this program, this vascular surgery program going. So yeah, that is the end.
Great, thank you very much for sharing that, Mary. I think one of the questions that I have, actually two questions I have. One is, I don't know what the COSEXA region curriculum is for vascular surgery, and I don't know if you've had a chance to look at that and cross-reference with that. And then the second thing, and in some ways a harder thing to figure out, is sort of how could you tier, or could you potentially tier what types of operations should be available in general, and then what next tier would be necessary if you had X additional infrastructure, and then and onward. So for example, like in our setting, we might say, talking about general surgery, we might say like every hospital needs to be able to do C-sections and appendectomies, but like not every hospital can do an aortic operation or has to do an aortic operation. But then the next tier hospital that has the right services might be able to do carotid operation, and then the next tier might be able to do aortic operation. And so those different operations require different things. And is there a way to tier that across all of the different operations in vascular surgery? So these are the first 7 things that somebody needs to be able to do, because this is based on the epidemiology and need that exists for vascular surgery. Is that does that make sense? What are your thoughts? Is that something that you all have discussed?
So COSEXA, I just looked it up. I was not aware of COSEXA. That's something that I will definitely look into and kind of reference.
Yeah.
I just like brief search, it looks like it's the Surgical Training Institution in Africa.
Mhm.
And so I will definitely look into that and see how we can incorporate it.
Yeah.
Anything that they have available.
Yeah. Yeah. And the reason I say that is so ACGME is what verifies, accredits our training programs in the US, but that's based on our needs, our epidemiology, our resources. And you should look at the equivalent in the African continent that applies to Rwanda. And so COSEXA may or may not have a curriculum related to vascular surgery. And if they don't, it would be useful to kind of think about whether this would be useful for them as well. Or if they do, how that differs. And they may have already tiered some of those things. So that's a step that's useful to consider. And actually, the one of the folks who heads the program, I think the program committee for COSEXA is in Rwanda. He's actually the dean of one of the colleges in Rwanda. So, he probably has access to some materials along those lines.
Okay, that is very helpful. Thank you so much. Your other comment about the kind of tiering, I have not talked to Dr. Brooks about that, but that is like a really good point. I would assume that like the most important surgeries that kind of everywhere needs to be able to do are like the life-saving things, and then kind of other places probably kind of more elective surgeries. But I don't, yeah, like we haven't talked about that. I don't exactly know what, like, I don't even know like what they really do other than based off their initial document, kind of the things that they were thinking about doing, but we're not 100% sure what they're able to do. But I will definitely talk to Dr. Brooks about that.
Comments from others?
Just a question, and maybe I missed it because I had to set a phone call. Do we know the volume of the different types of surgeries that are currently being done and where in Rwanda?
For vascular.
For vascular surgery.
Yeah, I don't know that we do have, I don't know that we have that information, but that's a useful thing to ask and see what is currently happening. Who's currently doing operations and what kind of operations they're doing. Is there a quick summary of that can be obtained, because that'll help you tier, right?
For sure.
Because I suspect most of the vascular surgery in most of Rwanda is going to be traumatic related, would be my guess, and not elective. And there be some at King Faisal and some of the hospitals there in Kigali that are doing more vascular type surgery things. But it'd be interesting to know what kind of cases, both in the major hospitals, but also in the rural areas, would be interesting to know.
Yeah, and there's an increased interest in dialysis and dialysis access in the last few years. So like that's a very common small operation where you basically connect an artery and a vein in the arm and the forearm to be able to allow dialysis to occur. And that's my guess is the need for that operation is probably skyrocketing, and I don't know if that is included in the training or what the volumes are for that. But understanding what the surgical volume certainly is a good thing to do, and that in itself might be worth a visit. To go to specific sites and look at their OR logbooks and kind of look and assess for the last year what kind of vascular operations have been done, and get a sense of that epidemiology.
Yeah, and similarly, sort of in vascular, Mary, so much of it here in this country has transitioned to minimally invasive. There's a lot of equipment and things that they won't have access to. So vascular needs, again, having a needs assessment and knowing the cases will be helpful, because their needs probably reflect ours in a years back sort of an area, because vascular is one of the fields where it's really moved forward to a lot of sort of technology dependent cases.
Yeah, and we have not really kind of assessed what they do or what they can do. all that I know right now is just based on like the module 17 that we were given initially and what they have as things that residents should be able to do. As far as the dialysis goes, like fistula creation for dialysis was one thing that was in the in their initial documents.
Great. Well, I'd suggest making a list of what we're discussing and then sharing that with Dr. Brooke as well, to say
Yes,
this
I
is sort of what input we got. And then it might be useful even to have kind of go over that, the conference call with the folks in Rwanda, which by the way, I'll be in Rwanda next week. So if there's anything I can do next week, let me know. Yes, Dr. Adolph.
This Adolph, yeah, yes, how are you?
Good.
Thank you. I'm sorry, I connected a little late, but I'm happy to hear from you and Dr. Mary talking about vascular surgery in Rwanda. So maybe come to questions asked by Dr. Raymond. Normally in Rwanda, we don't have vascular surgeon yet, but I know only one person who is vascular surgeon. Anything, any input, any innovation, any vascular surgery as it can be initiated by Mary or in residency program would be really enormous in Rwanda, because I know only one vascular surgeon. Others are general surgeon, orthopedic surgeon. We do have, and that one is only available at King Faisal Hospital, and you can't find any other or any elsewhere in England. I think would be very contributive to even residency training or whatever things we can think about.
Thank you, Dr. Adolph. Yes, and sorry, I should have probably given a little bit of that background. So Dr. Foston, who's head of surgery at the main public hospital and who helps run the surgical residency, he and I had met, and we met with Dr. Brooke, who's our chief of vascular surgery here at the University of Utah. And we were talking about what the vascular surgery capacity was in Rwanda, and the fact that there isn't a formal vascular training program. And so one step we thought would be a good place to start was just to look at what the training is for general surgeons, and to kind of work on upgrading that and working out a plan for ways to support that, either with remote teaching or in-person teaching, something so that that exposure is improved. And then to take that and of course model that into a fellowship, a longer, more than a couple of months, maybe a full year worth of training, as a sort of future step. So that's the background for why we've been looking at this curriculum. Other comments, suggestions? And yes, one vascular surgeon for a population of 13 million is like having one vascular surgeon for the entire Intermountain West, and more actually.